sending an email to those that still trying that not to worry, that it will be recorded for their viewing, and that they're welcome to keep trying, but if they're unable to connect, they can still view the recording.
Hi, Alison, definitely.
Okay. In the meanwhile, as David is going to lead us to the first slides, I suggest that the rest of us mute so that we don't have the feedback.
Okay, so thank you for those who are joining us on the line, and for those of you who've decided to watch this recording of the webinar. The purpose of this webinar is to give an overview of the planned event that was held for the simulation modeling methods cluster back in September. There were a number of individuals who weren't able to make the event, and people have found out about the event through different avenues afterwards. So this is a recording to give a sense of the discussions and to give people an opportunity to contribute to the development of the cluster. So if we can just move to the next slide. So my name is David Whitehurst. I'm an assistant professor in health economics in the Faculty of Health Sciences at Simon Fraser University. I'm one of the co-leads for the methods cluster alongside Nick Bansback, who's an associate professor of health economics at UBC. And there's two other important contributors who've helped to shape the work that we're doing for the methods cluster. Alison Holmes is a methods cluster KT specialist, and Alison has been valuable in terms of helping us and the other methods cluster within the support unit, so get up and running and through this development phase. And then Stephanie Harvard, who was recently Dr. Harvard, congratulations Stephanie, is working as a research associate with Nick and I on the work that we're doing in developing the early planning stage of the methods cluster. So if you can just skip forward, please. So the purpose of this webinar is to allow people to hear the information that was shared on the day of the planning event, to those who could make it on the day. And also, as part of a broader stakeholder engagement, we want to give as many people as possible the opportunity to share their thoughts to inform how the method cluster is developed. And one thing that we will be sort of encouraging throughout this is to invite you to share your thoughts over email or phone calls with either Nick or myself, to really give people as many opportunities to add their thoughts. So when the planning event was held back in October, what we were really looking to do was to lay this initial groundwork, to lay this foundation for patient-oriented health economics and simulation modeling research. And it was based around this idea of just initiating discussion among quite a wide range of attendees. So it wasn't just speaking to health economics and simulation modelers. We also wanted to talk to students and trainees and also sort of patient partners on the day. And a big part of this was to try and address some initial concerns that people may have about how patient-oriented research does fit with health economics, but very much to get everybody on the same page in terms of what we want to do is stimulate development of methodology in this area. So develop this community of methodologists that would all contribute to the cluster. Can you just skip? One of the things that we did want to address early on was trying to make a very clear definition about what patient-oriented research is and how this fits with health economics and simulation modeling. And really this underpinned the morning activities that we wanted to do on the day. So we wanted to provide some history and some definitions, and Alison will talk through that shortly. And then the rest of the morning was really about some clarification about the current patient, because a lot of the work that we do in health economics actually pushes us towards not thinking about an individual patient and actually thinking about broader sort of societal goals or thinking about trade-offs between different clinical areas. And then we've done a little bit of a review of research around sort of patient-oriented or sort of patient-engaged health economics, and we want to just give you a very quick summary of the work that we've come across in that review. So at this point, I will sort of hand over to Alison, who will explain a little bit more about the support units and methods clusters and really what patient-oriented research is.
Thank you, David. So I'm just going to cover a little bit of background material. The reason why we're covering this, and my apologies to those of you that are already really familiar with it, but one of the reasons that we're doing this is because we sent out a survey for people who were attending the planning day to share with us what they would like included, and many people just wanted a review of some of these key concepts. So I'm not seeing the slides at the moment. Zara, are they there? Okay, so can you all hear me?
Yes, coming through.
Yep. Okay, great.
Yep.
So what is patient-oriented research? Well, there's many definitions that are available in the literature. For the purposes of the BC support unit, there's 4 criteria. And those criteria are, first of all, it's a continuum of research that engages patients as partners, that it focuses on the priorities that have been identified by patient partners, that it is conducted by multidisciplinary teams in partnership with relevant stakeholders, and that it aims to apply the knowledge generated to improve healthcare systems and practices. Now, ideally, all the projects that the support unit supports and those that the methods clusters will undertake should theoretically fulfill each of these 4 criteria. However, there will be circumstances in which it's simply not possible to fulfill all of them, but the goal is to aim to do so. And the objective then is to ensure that there's co-development and co-use of the knowledge that is generated. Next slide, please, Zara. So just to clarify, SPORE is an acronym for Strategy for Patient-Oriented Research. And it's actually a coalition of federal, provincial, and territorial partners. And there's 5 elements, of which the support units are only one. So we don't say the BC SPORE unit, we say the BC support unit. And we recognize that the support units are just one of the 5 elements of SPORE. And there's 10 of them across the country. Zara, next slide, please. So support stands for support for people and patient-oriented research and trials. And there's 3 goals of the BC support unit. First of all, to build capacity to conduct and implement high-quality patient-oriented research in all regions of BC. Secondly, to increase the quality and the impact of that research throughout all of BC. And third, to ensure ongoing support for research that's occurring throughout BC. Next slide, please. So what are the methods clusters? Well, the methods clusters are the science pillars of the support unit. You can consider that there's basically 2 pillars. The first pillar is our service delivery. That's helping research teams to undertake their patient-oriented research. Then we have the methods clusters. They're the other side, the other pillar of the support unit. And their mandate is to advance the evidence base of scientific methods that are used within the context of patient-oriented research. by collectively fostering a community of methodologists and relevant stakeholders to engage in discussions and collaboratively undertake projects, and then to promote the use of that knowledge that is generated by the methods clusters. You see in this picture that we currently have 5 methods clusters: knowledge translation, implementation science, data science and health informatics, real-world clinical trials, patient engagement, which has not yet had its planning event, and then health economics and simulation modeling. We also just recently announced a call for lead for a new methods cluster in patient-centered measurement. Next slide, please. So that gets to a distinction in the mandate of the methods clusters as opposed to the service delivery side of the support unit. If you're undertaking a research project, a patient-oriented research project, and are looking for help with knowledge translation or health economics or data science for your particular project, then please click on the green button, which takes you directly to an inquiry form on our website. That's how you access support at the support unit. The methods clusters, although they do not directly provide support for individual research projects, clearly there's overlap between supporting practice and studying the science, and therefore there's communication between both pillars of the support unit. I'm going to mute my mic now and turn over to Nick for subsequent slides.
No, it's me, Alison. Sorry about that.
My apologies, David.
Okay, if you can just skip on, please. Next one. And the next one. Okay, thank you. Oh no, go back. Okay, so one thing that often comes up in the discussions that we've had with people is this definition of patients and whether that really fits with a lot of the work that we do in health economics. But if we look at the definition provided by SPOR of a patient, then you begin to see that it's a very broadly defined term. So in this context, patient is an overarching term inclusive of individuals with personal experience of a health issue and informal caregivers, including family and friends. So really this is anybody with experience of a health issue. And it's quite difficult to think of people either themselves or, if we include family and friends, that wouldn't meet that definition. So that's quite an important thing to clarify. If we can move forward, please. So in the review work that we've conducted over the summer, then one thing that we found was this paper that was talking about why patients should be involved in health technology assessment. So health technology assessment is part of the work that some health economists do, and it's a very significant part in which the contribution of health economics. And within this paper, the authors lay out 4 different arguments about why health technology assessment may be enhanced through greater role of patient partners. And this we're talking about from a patient rights perspective, thinking about patient and community values, experiential or evidential contributions, but also different methodological perspectives. And then in terms of patient rights, the authors go back to an Alma Ata Declaration of 1978, and really what they were talking about here is if we see health, whether that's physical, mental, and social aspects of health, as a fundamental human right, then people have a right and a duty to participate individually and collectively in the planning and delivery of their healthcare. But the idea that this added value of patient partners involved in research would help with building public trust in the health system and the processes that are then used to make decisions. In terms of community values, I'll address that slightly on the next slide, but if we just stay here for now. When we begin to think of sort of evidentiary contributions, then this is just really referring to the different experiences that non-researchers can contribute to the research process. And then in terms of methodological perspectives, we can think of many different aspects of research that could be improved and enhanced through greater collaboration with patients as partners. And one of the obvious things that springs to mind to me is sort of different ways of collecting data and thinking about the burden that we place on individuals and the processes that we can go through to make that a smoother process, which means that we can maybe lose fewer participants as we follow up patients in a study, and just different ways that we can really benefit from that. So if we can move to the next slide, please. And we'll go forward again. Okay, one thing we've also been interested in is this idea of how inherent the value judgments that we make in research. And this is work that's been inspired by Kevin Elliott. So the work that Elliott has done is really made it very clear that we make so many choices along the entire research spectrum. And at all these stages, we do make value judgments. And the idea that making a value-free decision or a value-free ideal is highly unlikely to happen. And what Elliott has talked about is trying to focus on making values transparent, representative, and open to scrutiny. And really what we're talking about here, sort of transparency in terms of where research decisions are based, not solely on scientific criteria, but on values, those should be made very clear. In terms of representation, if we do incorporate values, then we should try and represent widely held societal and ethical priorities. And when it comes to that openness to scrutiny is about engagement with a diverse community of scholars and stakeholders to make it very transparent and open about the work that gets done. So if you can just skip forward, please. So to think about an individual, a very specific example, then we could just think about how we choose a topic to study. And we could go through from thinking about a more narrow question. So within a particular patient population, do we want to study the effect of a drug, or do we want to study the effect of an exercise program? But then at every point that we've got to that decision, we could think about an alternative approach. By going one route or the other, then that is a value-laden choice. So instead of thinking about quite a narrow question about two different interventions for a particular patient population, we could actually think about other populations that could benefit from the research dollars that are being spent on that particular question. And it's just a matter of making these decisions explicit, but the point being that involving different stakeholders, and the patient partner being a great example of that, then that may actually lead you down a different route, and you actually may make different decisions. So we can skip forward. And again. And again. Great. Other work that we found was talking about whether the patient can be considered as the missing stakeholder in decision modeling. And this paper, again, talks about that moral obligation to try and unpick the black box of research that health economists do. So decision models can be very complex and difficult to understand, and this paper makes that quite a strong case for linking back to that moral obligation. We should be involving patients as equal partners in the work that we do. This paper goes on to talk about what the potential downsides of that could be. So that the positive side is the improved research, meeting that moral obligation, but this is also quite a big investment for all the parties involved. It's a big investment for the patient partners to be involved and also the researchers. And this paper suggests that many patients will not be suited for an involvement in health economics modeling, as they will not be able to rise above their disease. So really what this is saying is that it may be difficult in some circumstances for individuals to take themselves out of their particular circumstance and contribute efficiently and positively to the research process. So this raises that very obvious question that health economists will consider: is the benefits of this approach greater than the costs required to get this going? And this is one thing that we are going to be looking at very closely in the activities of the cluster. So if you can just skip, please. Thank you. And one example that we have found from the University of Sheffield in the UK is work that was related to a PhD thesis. And this was a study that used a conceptual modelling framework to help build public health economic models. And in this paper, we talk about, again, sort of the role of different stakeholders being involved in the research. And it refers to customers of the interventions, including patient representatives and lay members. So again, it's an example of bringing in patients as partners in the development of research. And one thing that came up on the planning event day was an interesting discussion about what it is that differentiates sort of patient-oriented research, patient engagement, just the mere fact of involving patients in your research. And this is part of what we want to do to try and get everybody on a level playing field in terms of what we mean by sort of true patient-oriented research. And this goes back to the definitions that Alison talked about earlier. So it's having patients as equal partners, ideally at all stages of the research. So developing the research question, deciding on how this is going to be conducted in terms of the design, all the way through to dissemination of research. So if we can skip that, please. Thank you. We've been looking at some international evidence from different places, so I've been thinking about work that's going on, because this isn't solely a Canadian initiative or a BC initiative. These types of processes to involve patients as partners in research is happening all over the world. And this is just an example from Denmark. So they, at the University of Southern Denmark, there is this idea of the patient as partner in Danish health research. This was funded back in 2016. And as part of this project, there's a very clear strategy in terms of activities to make sure the users of research and different user perspectives are embedded into all the research that's conducted. And as this slide points out, so those activities involve the mapping of activities at the project level. So it's trying to identify the role that patients play in research all the way down to an individual project level, and establishing sort of best practices and sharing materials that will be helpful. And this is an important thing for us to bear in mind, that we're not trying to reinvent the wheel if there is excellent work that's being conducted elsewhere. And we want to be aware of that and make these resources available and actually contribute something novel to the work that's being conducted. If we can skip forward. Okay. So on the day of the planning event, I mentioned earlier that we had sort of different people in the room. It wasn't just a matter of sort of academic health economists and decision modelers. We wanted to hear from the perspectives of different people. And on the day, we had sort of two researchers, Jude Cornelson and Vanessa Moonen, talk to us about how they think health economics and simulation modelling can contribute to their particular areas of interest. So Jude is very much interested in rural care, and for Vanessa, Vanessa is works at the Rick Hansen Institute and is very active in their research program there. So it's interesting to hear from non-economists about what they think this kind of initiative can really help them foster their own research and make a claim for better research in terms of bringing in an additional sort of disciplinary lens, so bringing in economics to the work that they do. And then on the day, Colleen McGavin also gave a patient perspective on what she thought health economists and simulation modelers could help in terms of sort of developing the methods for patient engagement and bringing in patients as partners. So if we skip. Okay, so at this point, what we would like people to do, whether they're on the line at the moment or they're watching this video further down the line, is to really get in touch with us. And there's multiple means that you can do that, either directly by contacting myself or Nick, or going through the support unit or through Alison, in terms of contributing your thoughts on what you think this method cluster can really contribute to research in BC and how it can strengthen research in BC. We're interested in any of your thoughts, so whether that could be sort of concerns about whether this sort of meets your expectations about why you joined this call or why you started watching this video. Are there aspects of this that you struggle to see the connection between sort of that very specific patient-oriented definition and the work that you are aware that health economists do or that you think that health economists do? But also, what kind of thing resonates with you? Where do you think those major contributions can really happen? So we really encourage you to get in touch through those different avenues to let us know your thoughts. And I think at this point, I'm going to hand over to Nick.
Hello. I'm not sure if you're able to see me. My video says it's working, but apparently you're not able to see me. But anyway, I'm going to keep going. My role of this presentation is to explain a little bit about what happened on the actual day in September for our planning day. What we did in the afternoon was we first presented to participants the results of our pre-event survey. So this is a survey that went out to a number of people that we had identified in the province who had expressed interest in this cluster, and we asked them, what kind of topics do you think would be interesting and required for doing patient-oriented research methods in health economics and simulation modelling? And sort of synthesizing those results, we sort of were able to sort of put these into sort of 4 bins, and I'll explain those to you now. So the first sort of bin was around the idea of measuring and valuing health and resource use that matters to patients. And so a number of people had given examples or ideas that this aspects of health and of resources that weren't routinely being captured in traditional economic evaluation and economic studies, which actually really mattered to patients. So, for example, valuing the sort of resources that were incurred by family members, particularly for rural health, perhaps these were not being captured into the formal economic analysis in as better way as it could be. But moreover, things actually in terms of quality of life measurement, potentially the domains that were being asked didn't capture all those that are important to patients and their families. And so this was one broad area that was identified in our survey. The second idea was around actually determining what areas of research should be prioritized, and how do we do that in a way that actually informs kind of research funding agencies which projects they should be funding. And so this is all around sort of projects and ideas where actually how do you best get the patient voice into those kind of selection and prioritization of research topics. And then the third area was broadly around communication, but actually communication in a number of different routes. So the first route was actually from the health economics simulation modelling community, actually being better at communicating the results and their findings to the sort of frontline workers and policymakers who actually use those results to make decisions. And so actually how helping the health economics and simulation community do better in that terms of how to communicate that information and evidence. That included like explaining difficult methods, transparency, let's talk about open source, the results and the data that was being used to generate those results. The second aspect of communication was actually sort of reverse. It's actually helping to articulate, well, why health economics and simulation modelling matters, and why should somebody who doesn't necessarily know too much about that, who's perhaps a frontline worker or a policymaker, about the potential for health economics in helping their research. And so that's the second aspect. And then the third aspect was around actually best practice. So how do we actually within the health economics and simulation community better help each other understand what we should be doing, what are the best methods that are available. So if you just move on to the next slide. The last was the kind of everything else box, which was so disparate we couldn't really put it together, but some really interesting thoughts, and it just showed to us that there's quite a lot of heterogeneity in this area. There's a huge number of methods that would be of interest. So if we move on to the next slide. On the actual day, what we did in the afternoon was we started off with, we did two group activities. The first activity was getting people into groups, first as a partner, then in a larger sort of in the small group, and then into the whole group, whole room, to sort of generate general ideas. So these were sort of just thinking about your own research, or the things that interest you, or the things that have resonated with you so far. What are some ideas that you think we as a methods cluster should be pursuing? And so this activity, we spent probably about an hour and a half going through this, and it came up with some really rich ideas, which sort of took on some of those ideas we'd heard from the pre-survey, but then took them a bit further. And so this was something that we did first. We then went back, if you move on to the next slide, to think about, well, some of these ideas were great ideas, but would probably take millions of dollars and tens of years of research. So we then were like, well, which of these ideas seem sort of feasible and achievable, which are easier than others? And so the groups then kind of worked and sifted through their ideas to sort of put a rating on the feasibility and how many people would be required, and the sort of resources that would be required. And so if we looked at those emerging themes, and that's something that we've been doing since the planning event, we then sort of further put them into sort of these 5 themes. Those others are still emerging. So the first theme was actually about the kind of theoretical underpinnings of patient-oriented research within the health economics and simulation modeling cluster. So this was actually questions about, why and how should this be done? What are the underlying sort of principles for this? And so that's one theme. The second thing was actually more practical, about actually engaging patients in this type of research. Questions like, which patients? How do you select patients? What methods work best in doing this? Realizing that engaging patients is, in a sense, also can be resource intensive, and how do we allocate our resources best to do patient engagement well in the most efficient way. The third aspect was all about diversity. So this was thinking about, how do we actually capture the values and views of patients from all backgrounds, and this is a very interesting area about kind of challenging us about not just listening to patients who is necessarily easy to make contact with, but also going out there to patients that can be harder to find, and actually then what's the added benefit of doing that. The fourth theme was all about values, and actually a bit more on the methods about ascertaining values. So there's different ways of asking somebody what's important to them, ranging from very simple questions of, is this important to you, from yes to no, that's the most simple way to actually then more advanced techniques about asking people to make trade-offs to ascertain how important something is. And so there was questions that have emerged around which of these techniques is most appropriate in which context. And then the fifth theme was actually around embedding the results of that into the system. How does this actually change the system? How can this be more than just research methods, but actually things that go on to have a real impact? So those are the sort of the themes so far, and others are still emerging. And so we are going to be writing up this into a document to summarize the findings of the day and all the other interactions that we've had, including the pre-event survey and interactions that we're having post the planning day, including any feedback that people might have from listening to this. So we go on to the next slide. So I think, again, in the interest of the fact that this is being recorded, I'm going to sort of come back perhaps at the end of the, I've only got a couple more slides, if anybody has any thoughts now. But if you do have any other themes or any of these themes you really sort of think, yes, we should definitely be doing this, we'd really be keen to hear from you about that. Anything new or anything that you'd like to make sure that we do consider as we make sort of decisions in terms of which of these themes we kind of take forward and prioritize ourselves. But if we move on for now. So just our next step. So yeah, so we're going to continue sort of working on these emerging themes, and we're going to be sending this a document out to everybody who participated in the day, but also people who've shown interest and who weren't able to participate. To sort of then tell them these are what we're finding so far. Any sort of thoughts, concerns that you want to add to that document. So those themes, once we've agreed on those, will be then used to develop some goals and objectives for our cluster. So it's really important to get those themes right. We'll send out those themes, and then we're going to kind of, in the next steps, there's going to be this final report that's going to summarize where we've got to so far. But then we're going to take this further and think about making a plan for what we're going to do in the next 3 to 5 years with our methods cluster, and sort of which projects we're going to fund that are going to meet those goals and objectives. So if we move on to the next slide. So at this point, I'm going to say thank you for listening to this event, and we would be here are our email addresses. Please feel free to reach out to us. We would be very keen to speak with you further. And I guess if that's the end of this formal presentation, perhaps anyone who is on the line and wants to sort of talk about something now, then I think we have a few minutes that we can talk about that now, or just think about it more and send an email to us later. So perhaps I'll just give you a couple of minutes, and if anyone wants to either kind of their hand or just speak, come off mute, then we're happy to discuss that now. I'll perhaps give you just a few more seconds if you would like to do that. Alison, I'm just checking with you if we've missed anything that you would like to share before we sign off.
No, thank you both David and Nick for that excellent summary of the discussions which were undertaken at the planning event. And I just encourage everyone who's either listening with us today or will view this later, that where we are with this theme development, where this cluster is also a reflection not only of who was at the planning event, but all the discussions that both preceded it and have occurred since the planning event. And that we're really encouraging everybody who has an interest in health economics and simulation modeling related to methods development to reach out and let us know what you're thinking, and to help connect us to other individuals who may be interested in contributing to the activities of this cluster. And with that, I'm sorry, I'm going to have to go because I have another commitment.
Great. Well, thank you, everybody, for joining us today. And please do feel free to contact us if you've got any further questions.
Thanks, Nick. Thanks, everyone.
Thanks, Nick. Bye.
Thank you.